or comments and submit it to the webinar organizers. You can do that at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we're unable to get to all your questions in the allotted time, Dr. Zwirling has agreed to respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on our website in the near future. So today, Dr. Zwirling will address opioid replacement therapies for opioid-dependent healthcare providers, the controversy. He will identify the impact of opioid dependency on healthcare providers, examine the contributions of genetics, professional acculturation, and professionally reinforced denial, review the relevant pharmacodynamics and pharmacokinetics of opioid replacement options, identify how prolonged drug use changes brain circuitry, or neuroplasticity, and how it contributes to chronicity. He will also review the definitions of safety-sensitive professions and the potential impacts of ORT on psychomotor and neurocognitive performance. Dr. Zwirling is the former program director for the University of Pennsylvania School of Nursing and Pennsylvania Hospital Nurse Anesthesia programs in Philadelphia. He is a clinical and didactic faculty member for the University of Pennsylvania School of Nursing Nurse Anesthesia program. He's also the course director for advanced pain management modalities at the University of Northern Florida. He maintains an active practice in thoracic, oncologic, obstetric anesthesia, and pain management. He currently maintains a full-time practice at Fox Chase Cancer Center in Philadelphia, Pennsylvania. He earned his BS and ANS at Hahnemann University, his CRNA at Pennsylvania Hospital School of Nurse Anesthesia, his master's in science at St. Joe's University, and his master's of science in nursing at Temple University, all in Philadelphia. He completed his Doctor of Nursing Practice, or DNP, at the University of Tennessee Health Science Center in Memphis, Tennessee. Dr. Zwirling's research interests include the neurochemistry of chemical dependency, clinical applications of preemptive analgesia, the pathophysiology of chronic pain syndromes, safety issues in interventional pain management, chemical dependency treatment for healthcare professionals, and the prevention of post-thoracotomy pain syndrome. He is the coordinator for anesthetists in recovery and a member of the AANA Peer Assistance Advisory Committee. He's a member of the American Association of Nurse Anesthetists, the American Association for the Advancement of Science, the American Nurses Association, Sigma Theta Tau, Psi Chi Alpha Eta, the Association for Medical Education and Research in Substance Abuse, or AMERSA, the International Anesthesia Research Society, American Pain Society, International Association for Research in Anesthetic Pharmacology, the American Academy of Pain Management and Society of Critical Care Medicine, Society for Airway Management, and the National Organization of Alternative Programs, among others. In addition, in his spare time, he is a member of the International Nurses Society on Addictions. He also is a diplomat of the American Academy of Pain Management. His real inspiration is to be the program director for the Orvis Fly Fishing School and to host an ESPN and special Angling with Art. So welcome, Dr. Zwirling. I'll turn it over to you.
Thank you so much, Dr. Fennell. I just have to point out to everyone that given that bio, which I look much, much better on paper than in person, the takeaway is it still costs me $5 to get a cup of coffee at Seattle's finest. With that being said, we're going to just go ahead and get started, and hopefully I'll be able to get the, there we go. I want to point out to everyone that funding for the webinar was made possible in part by a grant from SANSHA. And the views in the webinar, it's important to point out that the materials the speakers and moderators are using do not necessarily reflect the official policies of the Department of Health and Human Services nor does mention of trade names, commercial practices, or organization imply any endorsement by the U.S. government. But I do want to acknowledge that we are extremely grateful for participating in the grant and being able to provide some advanced training opportunities to our colleagues in the field. That being said, there are some people that I need to acknowledge before we get down into some of the, drill down into some of the research, and that are the people that have contributed significantly to our body of knowledge. And our body of knowledge, I have to say that mine is a little bit skewed. I work predominantly with anesthesia folks, so we in some ways look a little bit different. But I need to acknowledge Heather Hamza from UCLA, who has collaborated with the past 3 years with Ethan Bryson from Mount Sinai in New York in publishing 6 or 7 research and review articles, a few that have been published in the Mayo Clinic proceedings, a couple that have been in the anesthesia literature, looking at particularly the drug-seeking anesthesia provider, the anesthesia provider in recovery, recovery and relapse for anesthesia providers, and have provided the most contemporary data that we have available. We also need to recognize Omar Manjawala. Omar is what recently left the, oh my God, I just had a little brain infarct here. Omar is in the Midwest at one of the major chemical Hazelden Treatment Center, I'm sorry, and contributed significantly to raising the question of utilization of opiate replacement therapies in healthcare providers. We've had many, many productive discussions because Omar had the intellectual honesty to raise the question. And also participating in these discussions have been Paul Early, who is an addictionologist at the Talbot Center, Mark Sapala, addictionologist at the Mayo Clinic and Hazelden, Keith Bird, who's a anesthesiologist who essentially lobbed what he called lobbing a grenade into a stagnant pond when he raised the question about whether opiate-dependent healthcare providers, specifically anesthesia providers, should return or could return to the clinical arena safely. And Mike Orakovich, who is involved also with the Physician Health Program, I believe in Washington, and was, I believe, president of the Federation of Physicians Health Programs. In all of this, I have to share with you that the American Association of Nurse Anesthetists, vis-a-vis the Peer Assistance Advisors Committee, were the first people to promulgate standards, that specific to the reentry and retraining of anesthetists that were dependent, particularly on opioids or had a history of IDDA, and had shared those with all the nurses' health programs and all the physician health programs, alternative programs throughout the United States, not without a great deal of controversy and debate. And we'll talk a little bit about that as the presentation goes forward. Our objectives are really today to identify the impact of opioid dependence, in particular on healthcare providers, and examine some of the contributions to genetics, professional culturation, and what I refer to as professionally reinforced or educationally reinforced denial. Some of us in the field refer to that as terminal uniqueness. And we'll talk a bit about the relevant pharmacodynamics and pharmacokinetics of opioid replacements, but that will be more specifically to the pharmacokinetics, pharmacodynamics of buprenorphine products or buprenorphine-containing products, and a little bit about methadone. And we'll talk a little bit about the issue of neuroplasticity and how that underpins some of the issues around chronicity and relapse, particularly with opioid dependence. And lastly, we'll review some of the definition of safety-sensitive professions and some of the concerns we have about the potential impact of opioid replacement therapy on psychomotor or neurocognitive and executive functionings. The first thing that I want to point out is that, you know, having been around the chemical dependency treatment community for probably about 30 years now, one of the takeaways is really from Satayana, is that we need to remember that if we can't remember our past mistakes, we are condemned to repeat them. And I truly believe that there's some concerns that I have around the utilization of opiate replacement therapies that are best framed in some of the vulnerabilities that we have around pharmacologic optimism for pharmacotherapies in the treatment of chemical dependency. And that being said, what I want to point out is that I absolutely personally have no issue with risk reduction strategies in the appropriate setting with the appropriate professional supports. The other issue that I want to state is that there are any number of pharmacotherapeutic interventions that are available in the treatment of patients with chemical dependency who have comorbidities that are not addictive, are not have no potential for abuse, and are potentially supportive of an absolute drug-free recovery process. So I want to distinguish that there are some anti-craving supports that are available for our patients that are not opioid-based and that are supportive of the drug-free recovery process. That being said, it needs to be recognized that not everybody is ready or able to participate in a drug-free recovery process. Hopefully at some point they will be, and opioid replacement therapies for those patients may indeed be preferred at that time or indicated at that time. However, I want to point out, underline, and highlight for everyone that's listening out there that we're talking about a very specialized population today, and these are healthcare providers. And what I mean, definition of healthcare providers, are going to be physicians, pharmacists, nurses, and other defined healthcare professions. And we're going to be talking specifically about treatment of chemical dependency in that population. And what I need to point out, and we need to have clarity about, is that we're talking about a patient population that are licensed professionals. And by the given their holding a professional license to practice their discipline, there also is an additional responsibility that the licensing boards have into guaranteeing the public that this group of professionals, whether it be physicians, nurses, pharmacists, social workers, psychologists, or whatever, are fit for duty and are competent and safe to provide care. So a big piece of what we will be looking at is the responsibility that we have as healthcare providers and as policymakers to make sure that the folks that are providing healthcare in the United States are essentially competent and fit to provide whatever services we say they are trained and able and competent to provide. What I also want to point out is, and I think this is an absolutely critical article from C.B. McCracken in JAMA, May 19th of 2010, is the cautionary tale I want you to take away is that this young man is a PhD level psychopharmacologist who was working at one of the tertiary care institutions, world-renowned, contributed significantly to the psychopharmacology literature, and was living with another PhD level psychopharmacologist, and they were ordering buprenorphine products online. And he lost his paramour, his partner, to a buprenorphine misadventure. We don't know if it was because it was additives, excipients, or the buprenorphine. All we do know is that she died and they were not able to resuscitate her. And I highly, highly recommend that anyone in the field of chemical dependency treatment working with healthcare professionals has the opportunity to read the JAMA article, Intellectualization of Drug Abuse, from the May 19th, 2010 issue with the Journal of the American Medical Association. I just will read to you what from the abstract, which is that neither advanced education nor knowledge of pharmacology nor familiarity with the addictive process was able to prevent tragic consequences for me. It is my sincere hope that my experience may serve as a warning, help illuminate, prevent similar tragedies in the lives of others. And I share that with you because over the last about 30 years, I've worked with a lot of healthcare professionals with chemical dependency and a lot of very, very bright folks with chemical dependency, and the ability of extraordinarily bright people to keep balls flipping in the air and to provide smoke and mirrors that make it look as if CD is something else is remarkable. And I think the take-home message from that is that, at least for me, whenever I'm dealing with a medical professional where the question arises, where there's an inkling that chemical dependency may be the primary diagnosis, my bias is to have a comprehensive evaluation done sooner rather than later. What I want to point out on this next slide is that in terms of our own pharmacologic optimism, that over the years of looking at opioid dependency, we began with opium smokers, opium eaters, laudanum eaters, and then in the 1860s, opium begat morphine. And out of morphine, we began to see the soldiers' disease from the soldiers coming back with injuries in the Civil War, which was morphinism. And all of a sudden, we had a product from Bayer called diacetylmorphine or heroin that was purported to be non-addicting and a replacement for the morphine addiction that was the scourge of the early 1900s. And then as we found out by all of the folks that became heroin dependent, that heroin begat methadone for substitution therapy, and in a lot of ways, pharmacokinetically and pharmacodynamically, methadone, given its oral activity and its long half-life, became a superb replacement agent for people that were suffering in the throes of an IV drug addiction to other opiates. And then as time went by in the 60s and 70s, and it was in the 70s when we began looking at buprenorphine, heroin and methadone then begat buprenorphine, and buprenorphine then morphed into buprenorphine and Suboxone. For those of us that were married, or at least closely aligned with the agonist-free or the substance-free recovering division in the field, that begat naltrexone, which is a pure opioid antagonist that has no pharmacologic activity other than to block the opiate receptors from the opioids being able to attach and activate them. I have to say that in my own bias, naltrexone is the most underutilized and potentially valuable pharmacologic therapy that we have for healthcare professionals with a history of opioid dependence that are looking for supports to maintain a drug-free status. Just a little history, in '64 we looked at methadone and was first approved for the methadone maintenance programs. In '74 the Narcotic Treatment Act limited the methadone treatment specifically to the opioid treatment programs and added some incredibly burdensome regulations that makes it hamstrings the methadone programs from functioning as openly and freely as other treatment modalities. '84 naltrexone was first approved, but continued to be inadequately utilized outside of the opioid-dependent healthcare provider folks until in 1994 it was approved for alcohol addiction, and we began to see some utilization of naltrexone in the alcohol-dependent population, and now we're beginning to see the combination therapies of acamprosate and naltrexone, and some topiramate and naltrexone as well. '93, just a historic interest, levoalpha-acetylmethadone, which only needed to be dosed every 3 days, was approved for non-pregnant patients, but began to demonstrate a subpopulation at high doses having torsades, and torsades being a potentially fatal dysrhythmia shortly was taken off the market. In 2000, the Drug Addiction Treatment Act expanded the clinical context of medicated-assisted opioid treatment. And since that time, in the past 12 years, we've seen a tremendous expansion of the utilization of methadone and buprenorphine and naltrexone in the treatment of patients that have opioid dependency. And given the explosive increase, the absolutely astronomical increase in the number of patients that are flooding the detox centers and the treatment centers secondary to chemical dependency, to prescription medications, particularly the explosion in the use of oxycodone, oxymorphone, MS-Contin, the system has been absolutely overwhelmed, and there's been an impetus to get folks as quickly as possible stabilized on the Suboxone or Subutex as an alternative to the relatively high-dose oxycodone, oxymorphone, MS-Contin, hydrocodone dependency that we're seeing out in the population. Now, what I want to talk about a little bit is buprenorphine, and what before we specifically focus on buprenorphine and its pharmacodynamics and pharmacodynamics, I want to talk a little bit about genetics. I think the first thing that we as a group of treatment professionals really need to come to terms with internally amongst ourselves is the reality that the most predictive indicator that any of our patients is going to show up on our doorstep with a history of chemical dependency, be that opiate dependency, be that alcoholism, be that benzodependency, is a family history of chemical dependency. The genetic influences that permeate the families with chemical dependency issues is just stark. And what I mean by stark is that there are many, many of our young adolescents, children, young adults who may, unbeknownst to them, have genetic loading. And, you know, once the exposure has taken place and once the neuroplasticity has begun to evolve, the cascade of addiction is out of their control. And I want to need to be clear. What I'm saying is that the addiction is out of their control. Their recovery and responsibility for their recovery and their behavior is not out of their control. And indeed, I do believe there's a degree of personal responsibility that each of us has, regardless of whether we're chemically dependent or not. That being said, I think that once we contend with the biology and once we contend with the genetics, that the predominant thing that puts us at risk is our family history and the genes that we carry. And right now we're looking at least 26 different single nucleotide polymorphisms that are linked with increased risks for various forms of chemical dependency and other ingestive disorders, and that number will expand as we explore. We need to come to terms with placing chemical dependency squarely where it belongs, which is a physiologic aberration secondary to altered genetics in most instances that can be effectively treated. And we need to take it out of the morass of moral, our moral indignation about it. My years and years and years of doing this, I have not yet met an addict or an alcoholic or a nicotine addict that said that they went to their high school or junior high school counselor with the plan, an occupational plan to become a drug addict, an alcoholic, or nicotine dependent. And I think that the last thing I want to really say about that is that I work in a oncology hospital where I have a serious caseload of head and neck cancer and lung cancer patients, many of which have had laryngectomies and continue to smoke through their stomas. And that until we really take seriously and honestly the profound power of the disease of addiction and see it for what it is, then we will continue to undertreat and marginalize our patients. We really need to pay close attention to the physiologic and pharmacologic and genetic components that drive this process. That being said, I'm going to talk a little bit about the chronicity. One of the issues that happens, one of the things, if you listen to Nora Vocal, our director of the National Institute of Drug Addiction, talk about is that what we've learned is that the drug taking in and of itself is part and parcel of what changes susceptible brains. And the important issue in addressing that is what happens is we're changing very primitive parts of the brain, of the midbrain, in the reward and anti-reward mechanisms that absolutely have driven the evolutionary ability for organisms to survive and thrive. And when we're talking about the same kinds of reward and anti-reward mechanisms that have to do with procreation, eating, avoiding conflict, avoiding pain, we need to acknowledge that these reward mechanisms are trump at every crossroad higher cognitive functioning. And it's when we are able to address this issue of very primitive reward and anti-reward processes underpinning and subverting conscious behavior or cognitive behavior that happens in the frontal cortex, our higher cognitive decision making. It's when we begin to say, aha, that's actually what's going on. And what I'd like to tell you is that we really need to pay attention to the primitive drive system that's driving and undermining that conscious decision-making process in our patients with chemical dependency before we have a grasp of really what's going on. That being said, I think everyone is familiar with the pharmacology, physiology, neuroplasticity, and the issues around the pharmacokinetics and pharmacodynamics, hopefully, buprenorphine and methadone. I'm going to talk a little bit now about buprenorphine and Suboxone, which is buprenorphine with a naloxone added. And what I want you to think about is the sheer number of adolescents and young adults that are coming in opioid dependent that are being placed on Suboxone. What I also want you to think about is that we have two camps out there in the treatment community. We have those of us that are married to opioid replacement or risk reduction strategies. We have those that are married to drug-free recovery, often 12-step or other secular recovery processes. And what we need to have is a dialogue happen between all of these groups. And then we have a fair number of folks that are fairly eclectic and their approach and take a little piece from whatever works for that given patient. That's probably the camp that I reside in. What I want folks to take away with buprenorphine in healthcare professionals is that there's clearly some evidence that buprenorphine, even at a stable dosage, inhibits and causes some delay in psychomotor performance and some decrement in executive functioning. So my question to people is, given that, and given the fact that we have had an incredible degree of success with alternative programs that have mandated that a drug-free state and have monitored healthcare professionals for 3 to 5 years continuously, and have demonstrated in some states up to an 80 to 90% success rate at 5 years out, meaning that folks with clean urines, participation in 12-step or other communities of recovery have demonstrated by toxicology screening and participation in continuing therapy abstinence, why we would need substitution therapies. And one of the things that I want to point out is that Hamza and Bryson, in their article looking at opiate replacement therapy and healthcare professionals in the Mayo Clinic proceedings, surveyed every physician's health program and every nurse's alternative program in the United States, and the response was that a significant number of them would not share with us what their policy was, which already tells me what their policy probably is, and apparently did not have a particular position on the patient safety or public safety aspect of having a physician's health program or a professional's health program. What I will also point out is that currently in Pennsylvania, I know of one instance in where a licensed practical nurse is suing the state's alternative program, saying that they're denying her the ability to practice because they will not allow her to return to practice on methadone maintenance. And I put that out there not to say that they're isn't at any time an appropriate time that someone should be able to return to their profession on substitution therapy. What I put that out there to do is to raise the question of when, if any, time would it be appropriate to do that, and under what circumstances and what kind of monitoring would you do that. Regarding buprenorphine, what I want people to take away from is to remember that this is an opioid. It's 25 to 50 times more potent than morphine. It is a partial mu receptor agonist that has some kappa antagonist effect, and that may contribute to some of the antidepressant effect that we're seeing in some animal models like submersion, water submersion, and forced shock models. And hopefully out of that we'll see some novel antidepressants that work at the kappa receptor in the future. One of the things to keep in mind about the buprenorphine is we see a plateauing of analgesic effect, and the good news is there's a ceiling on respiratory depression provided there's a single agent ingestion, meaning that it's much tougher to successfully suicide with buprenorphine or Suboxone alone than other opioids. It can antagonize, depending on doses, fentanyl-induced respiratory depression without complete loss of anesthesia, and that's because of its incredibly high affinity for the mu receptor. And those folks that are on 40 milligrams or higher of methadone or methadone equivalent, you can certainly see it precipitate opiate withdrawal. So one of the things I want to get to is that it's been around for a while. It's been used as an analgesic for years and years, particularly for cancer pain and obstetrics in the European Union. It never caught on in the USA as an analgesic agent, and I'm not sure why. I just don't think it was marketed very strongly. And now it's widely utilized for opioid detoxification and maintenance. It is no question safer in overdose than other mu antagonists. This is the article that I refer to relative from Heather Hamza and Ethan Bryson that I hope everyone will have the opportunity to review and to read on their own. I think that it raises the questions about what we need to be doing in our alternative programs, and when there's the conflict between what's right for the healthcare professional versus what's right for the public at large. That being said, I want to make sure that folks are clear on this. Suboxone can be abused. Suboxone, the small amount of naloxone that's in the formulation, very little of it is absorbed when it's taken sublingually or orally. It is only when it is parenterally, when it is IV abused, that you see enough naloxone to give a dysphoric or an antagonist effect. So I want to kind of disabuse people of the notion that there's that much Suboxone that's orally absorbed that it will cause, naloxone that will orally absorb will cause withdrawal. It will not unless it's used parenterally. The naloxone is there to prevent parenteral abuse. Anyhow, what I would say to you in closing before we get to questions is that we have had a tremendous amount of success in our healthcare professionals, physicians, pharmacists, anesthesiologists, nurse anesthetists that are opioid dependent on placing them on depot naltrexone. If they're unable to get the depot naltrexone paid for 3 times a week, monitored naltrexone's Revia ingestion as an alternative. I prefer the depot naltrexone because we know that we maintain reliable blocking serum levels for at least a month or so, and which has absolutely no intoxicating effect, no effect on psychomotor performance, no effect on executive performance, and is consistent with a drug-free recovery process that's mandated by the majority of the alternative programs. So I do want to say that in that population that we work with, naltrexone is probably the preferred agent and is underused. We talked about this, and I'm going to, at this point, allow people to read this last slide, which really supports the what we've been saying about the potential for buprenorphine abuse. And it's a fact, these are the studies which demonstrate the risk of cognitive impairment with the utilization of Suboxone or buprenorphine subcutaneous in your practice. And with that, I will open it up for questions. I thank you so much for your time, your attention, and for your patience with my rambling. Thank you all.
Thank you, Dr. Zwerling, for an excellent and informative presentation. We do have one comment that came in, and I just need to have you verify the accuracy of this. Is today, in fact, your birthday?
Yes.
So if the phone lines were unmuted, we might be able to sing happy birthday, and I'll spare people from hearing me sing because it wouldn't be pretty. But happy birthday from the crowd.
Thank you.
So we do have on a more serious note, a question that came in, or a comment that just a comment. First of all, thank you for your presentation. Since we're all working diligently to have this disease viewed as a treatable chronic medical condition, then we need to start using medical terminology such as positive or negative toxicology screens instead of the terms clean, dirty urine, which only adds to the stigma associated with addiction. So,
well, I would say in response to that that actually I think it's more the treatment providers that have gotten their ire up about what our patients have come to take as normal terminology over the years. And, you know, there's a number of us that participate in a number of the online discussion groups, and there's many folks in the treatment community that take the terminology addict or alcoholic as incredibly stigmatic. And then we've also seen a tremendous degree of pushback from folks that are involved in the recovering community saying, no, that's my diagnosis, and that's how I identify. And I think it's going to take us a lot of discussion and a lot of years of coming to terms with agreed upon terminology.
Good. Another comment, I've seen I have seen cases of what appear to unquestionably be receptor supersensitivity following discontinuation of naltrexone used for extended periods of time. This has resulted in overdose with amounts of opioids which should have not resulted in overdose. Any comment?
Well, certainly I think that there's the possibility. I think that once we have that degree of blocking of mu receptors, in response you see a fair amount of proliferation of mu receptors, and I think that then there is indeed the risk for supersensitivity. And I think that certainly needs to be recognized, but not just with naltrexone. I think that it's often the case with folks that have been in an abstinence-based treatment for a while, coming off opioids, develop over months some supersensitivity, and may see a profound, exaggerated response to what people would anticipate would be a therapeutic dosage of opioid. I think that we all need to keep in mind that opioid dependency is often chronic and tends to relapse. That being said, with healthcare professionals, it's one of the few groups that we have seen, pretty consistently long-term recovery with. So I think, a big piece of that is because of the level of motivation and the time that we are able to monitor them for. But whenever we're dealing with someone with a history of opioid dependency, the risk of relapse and death is very real.
Another question comes in related to experience with naltrexone in chronic pain patients. The question is, does it negatively affect endogenous pain pathways, endorphins, and increase pain levels?
The data so far says no. And there was also some data back from mid-90s that looked at, there was some question of whether there was any loss of the activity of endogenous endorphins and in terms of affective disorders. And what turned out in the few studies that were done, the affective processes appeared not to be impacted. If anything, there was some improvement in mood. Many people that are, though, placed on naltrexone initially do have, the first couple of days, a mild dysphoric response. And it's not clear if that's how that's mediated, but the majority of patients, at least that we are treating for opioid dependency, not for chronic pain, see a remit from that dysphoric response in 2 or 3 days. So that does not prevent us from utilizing it. The other thing I would say is there's been some utilization of very low dose naltrexone along with immune receptor agonists like OxyContin or morphine, and some evidence that the use of that very low dose of the naltrexone decreases the amount of opioid-induced hyperalgesia and kind of slows the progression of tolerance. So at very low doses, we see probably different physiologic responses than blocking doses.
We do have a number of questions, and I thank you for agreeing to answer offline. I'm just going to pick one more for us before we close.
Okay.
How are state how are state alternative programs responding to the use of buprenorphine for participants?
Great question. The answer is there's 50 different alternative programs, and the answers have been anywhere from absolutely not to, well, if they're not in clinical practice, we don't and are appropriately monitored, and in a couple of instances, maybe with an addiction psychiatrist close supervision or addictionologist close supervision, that it's permittable. So the bottom line from my perspective is we need a lot more data. We need to study it. We need to fund some research looking at this, and we need to have open communications with the alternative programs and the modalities that they're utilizing and permitting, so that we know what is safe and what's effective and what potentially is harmful and needs to be avoided. And we don't know that until we get the data.
Mm-hmm. So there's a real opportunity for a researcher out there or somebody who's wanting to do some advanced like a DNP project or something like that. So
I have at least 5 or 6 PhD dissertations I can start tomorrow, and probably be at least 24 DNP capstone projects, just based on looking at the alternative programs.
Right. Well, thank you again, Art, for this really great presentation. Our time is up. I want to thank everyone for participating in this webinar. Shortly, participants will receive an email that includes a link to an evaluation survey. We would ask you to take a few minutes to access it and provide your feedback on today's session. This webinar today was recorded and will be posted on the events section of the INSA website, which is www.intnsa.org, as well as the website of the Prescribers Clinical Support System Opioid Therapies. That website is www.tccs-o.org. A calendar of upcoming events and helpful clinical resources are also available on that website. We hope that you will join us for upcoming webinars, and at this time I'd like to thank everyone for their attendance.